So welcome to Expert Perspectives from the Great Debates Oncology meeting in New York City in March of 2014. Commenting today are myself, Dr. David Ilsen from Memorial Sloan Kettering Cancer Center, and Dr. Axel Grothe from the Mayo Clinic. This has been a terrifically attended meeting with over 250 attendees. And in the course of the discussions, we've had very interesting debates, case presentations, and didactic lectures on a whole spectrum of gastrointestinal cancers. And perhaps we can start the discussion with the treatment of advanced colorectal cancer and the study of RAS mutations to direct the treatment of metastatic disease. Maybe Axel, you can comment on that.
Yeah, I can only echo what you said, David. It's a very well attended meeting, a lot of interaction, and we learned a lot. And we have the ability to poll people in these debates before and after the debates. Do we see a shift in opinion? And I think one of the shifts we try to achieve is the awareness of RAS and the all RAS, expanded RAS testing. So I think everyone in the audience, everyone who listens to this program knows that we need to test for KRAS mutation before we give EGF receptor antibodies like cetuximab, panitumumab in colorectal cancer. And I think this is part of our guidelines, it's part of the label actually for cetuximab and panitumumab. But I think, in the United States at least, we tend to ignore some data that came out of Europe actually in mid-2013, which led to label changes in Europe already, that we actually not just test for KRAS, we shouldn't just test for KRAS exon 2, the codon 1213 mutation, that's our commonly used test, but we need to expand beyond these conventional mutation testing to include all RAS testing, meaning KRAS exon 2, 3, 4, and NRAS exon 2, 3, 4. And then you can throw in BRAF and PIK3CA, whatever, but at least the RAS mutation analyses are very important. Eric van Kutzem gave a great talk today highlighting the data leading to this recommendation. There are about 15 to 17% of patients with KRAS wild-type tumors, how we identify them, that are actually RAS mutant. And those patients might not even not benefit from cetuximab and panitumumab, might even have a detrimental effect. So it's really a matter of patient safety that we identify these patients with RAS mutation. This is a DNA-based test, should be easy to do. I know the FDA is looking at this right now. I think this is a very important point. Standard of care should be comprehensive RAS testing.
Yeah, so I think really the new standard of care is any RAS mutated tumor should not receive EGFR targeted therapy, and that in the previous situation where we were limiting testing to exon 2, another 17 to 18% of those patients are going to have other RAS mutations, and the data consistently across studies show no benefit for adding cetuximab or panitumumab to treatment, and actually, as Axel indicated, show the same detriment that we see in the exon 2 mutations. So I think all RAS testing is a clear message that emerges from the discussions. Another area of interesting debate was which chemotherapy regimen should we pair with which targeted agent? And I think consistently, given the cutaneous toxicity that we see from the EGFR therapies, that we should avoid the use of capecitabine combinations when combining chemotherapy with EGFR targeted agents. My read was there's really not a clear indication of a difference whether we use FOLFOX or FOLFIRI with EGFR agents. Maybe a little better data for irinotecan and bevacizumab versus FOLFOX plus bevacizumab, but I think you can comment on that as well.
I think it's, the problem is some of these trials had differences in where they were conducted, how they were conducted, how long patients were treated, et cetera. There's some heterogeneity even in by country outcome in the large multinational trials. So overall, I think, except for what you just said, capecitabine and EGF receptor antibodies, which really doesn't seem to work well together. I think everything else is up for grabs right now, and we have more data coming out from the head-to-head comparisons between cetuximab, bevacizumab, for instance, with different combination partners in the CLGB SWOG trial, more FOLFOX, a little bit FOLFIRI, in the German FIRE3 trial, more FOLFIRI. I think eventually the dust will settle. We'll say, it depends more on the patient than and preference in terms of toxicities than the actual interaction between these biologics and chemotherapy.
Yeah, and I think the issue of what's the optimal initial targeted agent in a RAS wild-type population, we're really awaiting the results of 80405, where it's the overall survival is the primary endpoint and a real head-to-head comparison first line of bevacizumab versus cetuximab to get a clearer indication. Already data out there, like the FIRE3 trial, do suggest at long-term follow-up a potential survival benefit for initial use of cetuximab plus FOLFIRI versus bevacizumab plus FOLFIRI. But the odd and inexplicable aspect of the data is why the survival curves don't really separate until almost 2 years into treatment. I think, again, we'll really await the 80405 US results to see whether there really is a difference in first-line selection of EGFR versus anti-angiogenic therapy.
Yeah. So I think it was interesting for us to see here at the debates meeting, we talk about colorectal cancer, but the audience was actually really intrigued by discussion about biliary cancers. This is a topic we normally don't put on the agenda that commonly, but there are a lot of discussion, a lot of questions about biliary disease, probably also because there are not that many studies out there. We had some discussions about adjuvant therapy after resection. People do it, although there is no data. Do you use, let's say after resection of a cholangiocarcinoma, do you use gemcitabine alone or gemcis, which seems to be it seems to be more active in the advanced setting. Should use radiation therapy, yes or no, in what settings? I was intrigued by the intensity of the discussions, the numbers of questions raised by the audience. So it shows me, and number one, we need to keep this on our agenda. Number two, there's really a need to define standards of care beyond just expert opinion, but it's not easy to conduct clinical trials.
Well, I think what emerged from the discussion is that this is also a heterogeneous group of diseases. That we have intrahepatic cholangiocarcinomas, extrahepatic cholangiocarcinomas, and the gallbladder cancers. And the consensus was that the gallbladder cancers tend to be more aggressive tumors in the setting of node-positive disease. There is a consideration for systemic chemotherapy, really modeled on the benefit of gemcitabine in pancreatic cancer, as well as the meta-analysis data that do suggest a potential survival benefit that almost reached significance for a gemcitabine-based adjuvant. Then there was an argument, if we're going to give chemotherapy with the limited data, because in advanced disease, we now have phase 3 data from the ABC trial in Britain in biliary tract cancer that a combination of gemcitabine and cisplatin is superior to gemcitabine alone. So some on the panel would extrapolate that to the adjuvant setting, that gemcitabine cisplatin should be the preferred adjuvant. Others argued for gemcitabine alone.
Do you use adjuvant therapy?
I do, and I tend to use gemcitabine alone because I think the argument came up a number of times. FOLFIRI is great in metastatic colon cancer, but irinotecan adds nothing in the adjuvant setting. And there's always a potential to do harm when you make treatment more complex and more toxic.
So I use gemcis because platinum agents have not disappointed in the adjuvant setting in any disease. So
well, that's not necessarily true. Gastric cancer, there's data that adding platinum to 5-FU in the CLGB 80101 study, adding platinum to 5-FU added no survival benefit. There's also Korean data. So it's not always clear whether more is better. And then there was a lot of discussion about the role of adjuvant radiation in biliary cancers, and the consensus was that that should really be limited to margin-positive patients, not a clear benefit after a complete negative margin resection. And then an interesting discussion about the sort of borderline unresectable tumors, giving upfront chemoradiation, and even a paradigm for upfront chemoradiation followed by transplant, leading to some favorable survival outcomes. So
in highly selected patients.
In highly selected patients. Yeah. Then we had some interesting discussion about the state-of-the-art of targeted agents in hepatocellular cancers. Sorafenib by itself really remains the standard of care. This is the multi-targeted tyrosine kinase inhibitor. No drug has really shown a superiority to sorafenib, nor have any combination studies indicated a benefit over sorafenib alone. We do have the ongoing CLGB Alliance study, which looks at standard sorafenib with or without the addition of doxorubicin, based on some intriguing phase 2 data. And then obviously the areas of interest include c-MET-targeted therapy and VEGFR-targeted therapy. Unfortunately, some disappointing results for the mTOR study in hepatocellular cancer, the everolimus study not showing a clear any survival benefit versus best supportive care after sorafenib failures.
I think we had, shifting to a different tumor, pancreas cancer, interesting to see how do we integrate these two new, let's say, first-line standards of care, FOLFIRINOX, modified FOLFIRINOX, versus gemcitabine nab-paclitaxel into our treatment algorithm. We had a debate about, what is the preferred first-line therapy. And interestingly, although I can see there is some push toward, from commercial vendors toward nab-paclitaxel, because, FOLFIRINOX, all these drugs we use are generic now. There's really no big commercial interest from companies behind it. The vast majority of the audience actually supported FOLFIRINOX as first-line therapy, and this mirrors more or less what we're doing at Mayo Clinic too. We drop bolus if you use FOLFIRINOX, use gem-Abraxane in patients with good performance status, second-line therapy.
Yeah, well, I think the
nab-paclitaxel.
Yeah, I think in the debate it was interesting to put up the data side by side, because some would argue that the FOLFIRINOX trial had a better selected patients, that this is one of the reasons that they perform better, and that the nab-paclitaxel regimen might be a little less toxic. But I think both of those points were refuted, really, because if you look at the head-to-head comparison of the trials, the control arm, gemcitabine, behaved absolutely the same in both the IMPACT and the PRODIGE studies. So the gem control arm was the same in the nab-paclitaxel study, and the gem arm behaved the same in the FOLFIRINOX study, really arguing that these were really much more comparable groups of patients. And if you actually line up the toxicity profile, they're actually quite comparable. Similar rates of neutropenia, maybe a little more diarrhea with FOLFIRINOX, but not insubstantial toxicity with gem-nab-paclitaxel also.
I agree.
And I think really the audience really selecting FOLFIRINOX in a good performance status population was really based on the survival and PFS benefits, because when you line up, as Jordan Berlin did, the hazard ratios, when you're talking about a hazard ratio of 0.5 versus 0.7, a doubling of benefit versus a 30% reduction, the data argue better in a good performance status patient that FOLFIRINOX probably gives the best survival and progression-free survival, that the gem-nab-paclitaxel might be the treatment of choice in a lesser performance status patient that you don't think is going to tolerate the rigors of FOLFIRINOX. Whether or not second-line gem-nab-paclitaxel has efficacy, it's not really been studied. And then that came up into the discussion of what do we do second line, and that there are data for FOLFOX being superior to infusional 5-FU alone in gemcitabine failures. And there's a lot of interest now in looking at refractory pancreatic cancer with a number of interesting new targets, including PARP inhibitors in BRCA mutant tumors, stromal degrading agents such as hyaluronic acid, and even immunotherapies looking at GVAX, which targets this mesothelin antigen, very provocative data from the Hopkins group combining GVAX with an immunostimulant led to survival benefits compared to the GVAX protocol alone. And that's prompted now a randomized trial comparing immunotherapy with second-line chemotherapy in patients in the second-line treatment of pancreatic cancer.
I'm very excited to see that we have treatment options now more than ever before in pancreas cancer. It's a tumor where we see a lot of research being conducted, and I'm hopeful that we will really see at some point in kind of cancer statistics improvements in outcome, because we really hadn't seen improvements in outcome over decades.
Well, we have no biomarker, and that was another point of discussion. But even in colorectal cancer, really all we have as a validated biomarker is a RAS status. And then I think lastly, a lot of interesting discussion on the management of rectal cancer. A very vigorous debate about the management of T1, T2 tumors. Certainly for T2 tumors, there was this discussion about organ preservation versus upfront surgery. That is a T2 N0 tumor, you could consider upfront surgical resection, or some would argue for chemoradiation with local excision with the hopes of sphincter preservation. And I think the interesting upshot was that this type of an approach should be individualized to each patient. Long term, with the sphincter preservation route without surgery, there are higher rates of local failure and trends towards inferior survival. So I think most of us would argue in a good surgical candidate to proceed with upfront surgery for a T2 rectal cancer. The issue of organ preservation using chemoradiation and local excision might be tolerated for the older patient with comorbidities or a patient that declines surgery, the patient that just refuses to get an ostomy if it's required. But certainly there are concerns about the sphincter preservation approach leading to higher local failure rates and poorer survival long term without the use of surgery.
We shouldn't forget to mention that Kathy Eng and Deborah Schrack, I both mentioned the ongoing intergroup trial, which will try to see whether we can improve our kind of strategy toward the rectal cancers, mid and high rectal cancer, not the low ones, where we really have to sacrifice sphincter in a lot of patients. But those patients who with mid and rectum and high rectal cancer, the question is, do we really need radiation therapy? Something we've been discussing for quite some time. So there's a randomized trial right now in the United States comparing chemotherapy, which we know can work on a primary tumor in the rectum, and selected radiation therapy for those patients who don't respond, followed by surgery, compared to standard chemoradiation followed by surgery. So that was important.
Based on very provocative data from Memorial Sloan Kettering, that preoperative chemotherapy alone led to even significant rates of pathologic complete response. And in their series of 32 patients, I think only 2 patients required the addition of radiation as part of their treatment. So the national trial is now trying to assign patients, randomizing patients to the standard of care, which for a T3 or node-positive rectal cancer would be preoperative chemoradiation followed by surgery. And then the experimental arm would be starting patients on induction chemotherapy with FOLFOX for 3 months. If they have a good response to treatment, then taking them to surgery without radiation, versus if they have an inadequate response to neoadjuvant treatment that is essentially less than a 20% response, those patients would be selectively given a preoperative chemoradiation. We already know that in selected patients with T3 N0 rectal cancer, we actually do avoid the use of even of postoperative radiation. And remember, the key is also the quality of the surgery, that all patients need to have a total mesorectal excision as part of their surgical management, which I think has really put into clearest perspective which patients may actually benefit or not benefit for the addition of radiation. But the take-home message from the discussion also was that the standard of care does remain in a T3 or node-positive rectal cancer preoperative chemoradiation, preferably with capecitabine based on the recent data, capecitabine radiation followed by surgery being the standard, but a lot of hope and interest about the use of neoadjuvant chemotherapy alone and the more selective application of radiation in patients that we think really would require it.
So we can see there are a lot of new kind of areas of research. There's a lot of new data. There's sometimes confusion about how to develop best strategies for patients. I think that's what the great debates are about, that we can actually sort this out, that we can push and put different opinions against each other, and really kind of then use panel discussions to sort out and come to a consensus. And I think for someone who hasn't been here yet, at our meeting, which will repeat next year in New York, they should come and listen in, because I think it's a very comprehensive way of really getting a lot of data in a very nicely infotainment-like way in GI malignancies.
Yeah, well, I think really the debates really allow a point-counterpoint discussion of the different approaches, which we clearly, I think, highlighted during this review. The case presentations really allow to put the data and discussions in a clinical context, and then the didactic lectures really have served to update the audience about what's the latest in research developments and where we think the field is heading, which I think we're all very optimistic and excited about many new developments. So, Axel, thanks very much for working together with me on generating these perspectives from the Great Debates meeting, and we really look forward to continuing this in the future.